Hello, my coding family. How's it going? How's your Friday? Sorry I'm late. It has been a busy, busy day. Started with 7 a.m. this morning. It was crazy. I had workers scheduled for Tuesday to put in a fourth air conditioner unit, a 1-ton this time, and one of the other back addition bedrooms, and there was some miscommunication, and they ended up coming this morning instead of Tuesday morning. So I had to scramble and get the room ready for them this morning, but it took them 2 hours and they got that thing installed. It's great. It'll be good for this summer. And my mom had physical therapy, and her hired CNA came by for shower time, so that was great. How's everybody doing? Hello, Eva. Hello, Aisha. SK, Go-Kart, Emily. Can you guys hear and see my starting screen? Oops. Hey Mabel, hey Joni, hey Victoria. I'm so glad you did remember to check. Hey Yasmin, good to see you. It's been a while. Hi Maisha. Yay, I'm so glad y'all can hear me. Let's see, we've got just 12 people on tonight. It'll be a light night because a lot of people don't know to come on Friday nights. But I'm so glad y'all are here. I hope I can help you guys. We got 8 likes on the YouTube for today already. I haven't even said nothing. Let me get to my Word document. I've totally messed this thing up that my son set up for me, but I don't know how to fix it. So it is what it is until I let him know that I messed it up, and he yells at me and fixes this. But I can manage. We were talking last night about ICD-10 indexes, and if y'all got any questions y'all want to ask, feel free to jump in and ask questions. And I just wanted to go over some of the things that I couldn't show you last night because the camera wasn't working. You guys know that we have the 4 indexes in our ICD-10 book in the very, very front. There are 4 of them. Not only do we have the alphabetical index right here of diseases and stuff, we have the index for neoplasms, the one for drugs and chemicals, and then the ones for the index external causes. A lot of people don't know there's 4 of them up there. They all know about the alphabetical index, and usually know about the neoplasms, but the chemicals and external causes get lost in there's so much information flying at you when you're starting out doing diagnoses. This is probably terrible and something you can't see, but just a screenshot I found of what some examples are of what you will find in the index for diseases, right? You'll find angina, fracture, pneumonia, that kind of stuff. In the neoplasm table, you'll find examples like lung cancer, those kind of things. In the table of drugs, we've got aspirin, Coumadin, those kind of things. Petroleum are found in that one. Coumadin is a favorite. And then in your external causes, this is where you'll have fire, you were hit, you were stung by something, those kind of things. Mary Ann, you passed? Yay! I hope I helped you out. I hope I made a difference. That is great. Thank you so much for stopping in to let me know. That is such wonderful news. Did you take your exam today? Or just get your results back today? Did you take it remotely at home, or did you take it at a testing center? How was it? Was it terrible? Was it awful? Was it nothing like I said? One question that you've never heard of. Interesting. I wonder what in the world it was. Something about a modifier and can be used to bypass the NCC edits. Ooh, that's a good one. Anybody know what modifier bypasses any NCCI edits? That is a crazy question because we don't do a lot of billing in CPC, and for them to ask about that. If your NCCI edit has an indicator of a 0 or a 1 beside it, then you can use a modifier to bypass that if it's paired with something. So let me see if I can't find something to bring up. It's crazy they're asking that billing question. Let me see, can I add it here? Insert picture from device. Pictures, screenshot, this one, insert. Let's see. Yasmin says 25 and 59. Yes, I passed. Really, it's all because of you. Aw, today you took it at a center. It was not bad. Just as I said, great. You lock up your purse and keys in a little locker and you use their computer. They're not sitting behind you monitoring you. They're just giving you access to their computer. You'll still log on with a remote proctor who then watches you, but they've already got all the equipment set up, hopefully appropriately. That's great. While I was taking the exam, I heard your voice saying, do not read the question. That is awesome. She chose modifier 59. Let's see. This one says, this little thing says what here? 59 in these edits is not bypassed. What does that mean? For Medicaid, bundling edits. Okay, but we're asking about Medicare probably, I wonder. CMS defines modifiers. Yep, we got anatomical, global, and other. Modifiers may be appended, blah, blah, blah. It is important that we only use them when they're appropriate. Under general circumstances, separate encounters, yeah. Each NCI edit, PTP edit indicates a 0 or a 1.
Also, do you want me to bring the salt in, or do you want me to put it in the machine too?
Put it in the machine, babe.
Okay.
Thanks. And then throw away the empty bag.
Yeah,
Try not to spill too much of it on the floor.
Okay, I already put water in the machine, water bowl too.
Okay. And Grandma had water jugs outside that need to be put into her room near the her water jug machine.
Okay.
Thanks.
Didn't you take a nap though?
Nope, she's awake right now. Medicaid. If the indicator is a 1, I know you could use it. It could be used to bypass the edit. So if your example would have come with a chart on the CPC exam, and it would have had a bunch of modifiers, but it would have had a column for that edit with 0 or 1, whichever modifier happened to be with the 1 is the one that you would have picked for that question. But there would have been a little charty thing, I think, that would have gone with that question. I was really surprised, yeah. Is it a good idea to practice on a CCA practice book? I practice with you guys with a CCS, a CCA, a CPMA, a COC, CIC, you name it. I practice all kinds of questions with you guys. I found a lot of the COC practice example questions were on my exam, like 3 or 4 of them were on my exam, and they came from the COC course. So I use anything with that has practice exam questions. That's really good info, Marianne. That's great. I was really surprised by that question. The other questions were familiar to me, but the E and M you guessed at. Aw, I wonder how you did in your breakdown on the E and M. It's only 6 questions, but some of the cases could have been E and M at the end too, but hopefully it wasn't too bad. I know last night we did some challenging questions, but it's exciting. So we were talking last night in the ICD-10 line book about indentations and carryover lines, and I was trying to explain it, but it was really hard without showing you the book. So for this example, I was going to try to show you. Let me make this bigger. So if this is the copy of the ICD-10 alphabetical index, we know we have our main term right here, right? This one is a carryover line, and then this one is a subterm. Right there. This one is subterm. We've got subterm. This one is a carryover, right? Sub, 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 carryover, sub, carryover, and sub. And how do we know the differences is what I was trying to show you guys last night, and didn't know how to do it without a book. and my camera wasn't showing. The carryover is just a continuation of the first descriptor of the sub line right here. This membranous and J40 is just a carryover. It's just, you see the comma right here? It's just a continuation of the first line. They just ran out of typable space and had to scoochie it down here to another line. So that's why that's just a carryover, and why this one is a subterm. And you can see the comma right there. That means that that goes with this sentence. Should have been up here. They just ran out of space. The interesting thing is, if you have an electronic version of the book, there are no carryover lines, because everything fits so far from what I've looked at in the ICD-10 book. Everything is just a sub term if it's not the main term. So that's kind of cool. I also am trying to figure out what our color codes mean here. What is the purple versus what's the green and what's the orange? I'm curious as to those definitions. I can't find it in my ICD-10 book. I'm wondering if maybe you guys know what they're calling those color code coordination, or and if you don't know, well, I'll keep looking and see what I can find. But I thought that was interesting. Sorry, I'm trying. My draw tool is being a pain. No, I don't want to be in the header. Here we go. And I want to just erase. But because I thought there was something going on with these color codes, but there are no carryovers when you're in the regular book. You can see my regular book here that I went there and tried to do this. Like, this is our main term, which is that big indentation right there. We have a carryover because this membranous was supposed to be up there. Then we have our subterm with, our subterm influenza. But see, we have a comma, so that makes the next line a carryover. And then on with the subterms until this carryover I almost missed right there, because it wasn't no comma, it was just an or an and. And then that made that line a carryover, and then these are subterms. I just didn't write all of them all the way down. But I don't think we need to know any of this really for the CPC exam, that which line is a subterm and which one is a carryover. But it does explain, some stuff and what they're doing in the book and why they have it indented in certain ways. But I really like the color coding that they've got going on in the electronic version, and I want to know why. Why are these green when these are orange, and then these are purple? There's got to be a reason with it. I thought maybe with the acute, but acute could be purple, and then over here there was an acute that was in the orange, so that's not it. But I wonder what's going on there with those color codes in our electronic version of the book. Let me check chat and see what you guys have been saying. To ask about the bundle packages, if you are on my website at Medical Coding by Jen and you're at the shop, as you put stuff into the shopping cart and you hit a certain threshold, like $100 or something, you will start getting coupons to come off of your items. The chapters are so large in some areas, like cardiovascular or medicine section, that it's really hard to get one file to download with the entire chapter copied in color. So I can't make like one file where you download the entire 1,000 pages in color. So no bundles, but there's an automatic coupon that takes 25% off or whatever as you start adding stuff in for the CPT book notes. The ICD-10 notes are super cheap, like $10, whatever. They're not expensive at all. So the CPT notes have a coupon for sure. So as you add those up, you'll get a break on that. Plus there's a loyalty program on there. As you spend money, you will get money back that you can add to your shopping cart on top of coupons that automatically populate. You can add in and take loyalty points off your next purchase, and you can combine those two coupons to get bonus stuff off. Let me check. She chose modifier 59. Yeah, interesting question. I'll see if I can't find that question. It was, and I think 22, 59, and 76, and I can't remember. Awesome. I have to look at the breakdown. That's great. So there would have been a chart, and the only one on that chart with the number 1 on it, the other ones would have had zeros. That's the one that had the bypass edit. And that's a CPMA question. That's inside the course for CPMA, by the way, not CPC. That is crazy you got that question today. But you never know. They have a pool of questions that they pull from and can generate a unique exam for anybody. Red looks like main terms. Yeah, it sure does. Purple is the first modifier. Green is the second. Orange is the third. First modifier? I wonder what they're talking about. Very interesting. One place it said up here in this little printout that I got, it said let's see if I can find it. Here it is. Indentations that are 6 characters in length represent carryover lines. I can't get my book to match up with that, but I want to know what the heck they're talking about right there. Indentations that are 6 characters in length represent carryover lines. When I go back to our book and our example from the same person who wrote that sentence, they're saying that this carryover line for this J40 is 6 characters. Now I was assuming they were talking about an ICD-10 code being 6 characters long, but the J40 does not require that you have 6 digits with it, so that doesn't match. My next assumption is that whatever word was going to come over here, if it's over 6 digits long and it's going to be more than that, then it constitutes creating a carryover line. But the way they wrote that sentence confused the heck out of me, and I don't understand why they wrote it that way. But anyway, maybe you guys can enlighten me. Indentations that are 6 characters in length represent carryover lines. Period. What? I don't know. I just try to make sense and show you examples of what I think they're talking about. but they claim this one is a carryover. Yes, yes, yes. And this one is a carryover. And the rest are subterms. I bet Marianne was so nervous today. I know that's a stressful Friday. Not modifier, but subterm. Okay. The first subterm, the second subterm. Orange is the third subterm. Subterm. Okay. The purple is with bronchitis, with influenza, obstructive airway, and trachea. But it may not be, and then we could have bronchitis that skips the green diagnoses and could be only acute, chronic, or under an age. So it's another set of subcategories. Okay. Interesting. Hard way of looking at that. Then we've got another one that starts over. We either have bronchitis with acute and subacute bronchospasms or obstruction that could also end up with COPD, or a chemical due to chemical gases, fumes and radiation, those kind of stuff, or strep virus. Very cool. I knew you guys would be able to help me out with things I don't understand even. Yeah, I didn't understand none of it last night either. It's hard to do without the book. Jen, I'm going to go rest now, but I'm going to send coworkers your way. She's a phlebotomist and now works in the lab with us, but she needs a career to elevate her salary. She's a single mom. That's awesome, Marianne. I hope I can help her. That's great. No worries, Victoria. That's great. You rest. Thanks for the info. If you think of anything else that could help anybody else out, you can always email me at medicalcodingbyjen@gmail.com. Thank you so much for that info about that code for the CPMA question that was on your exam today. That's crazy. I've got some examples of those that I can bring out. So I have a little matchy match here. Ooh, y'all may not be able to see it. It's really small. Bring this up on the screen some. There we go. Make it a little bigger. Maybe I made it too big. If we're looking for a symbol, we can underline the word symbol, because some of them aren't going to be symbols, right? Okay, good. And then anything that doesn't have the underline is something that's different. Like number 2, where you can find reference articles. So reference articles is something different. There's a tabular list. There's instructional notes. There's pages. There's appendix. You know, those kind of things are all different. But when I'm doing these wordy questions, I like to break them up into different categories. Maybe do all the symbols first and then do the other stuff last. Because, you know, we can see the little symbols over here to the side really easily. What's a symbol that denotes an additional character is needed to complete the code? when it says an additional character is required. That's funny. All right, what about here? You can find reference articles that give you coding advice. That's got to be that AHA coding clinic, all that stuff down at the bottom of the codes that are in the way. And I hate that our CPT books have those in there, since we can't use that information on the CPC exam. It's in the way. Number 3, a symbol that indicates a code that should not be used as a principal diagnosis. Oh, Travis is banned. Oh, what have we got in chat now? You passed? Niru? Awesome, that's 2 tonight. Mary Ann passed today too. Congratulations. Oh, I'm so happy. Thank you so much for stopping in to let me know. It made your papers easy. Oh, that's great. Congratulations. Don't forget about the I symbol. Any of those symbols, super helpful. You do have note pages in your ICD-10 book that you can write full pages of notes on. Super helpful. Don't forget about the Z code list in the front of your ICD-10 book and the guidelines. There's a list of all the Z codes that can be used as a principal diagnosis. Super helpful to utilize that page during your exam for sure. I've got a case here that we can work on. It's got 3 questions. They want us to do the E&M level, the amount or complexity of the data that's in the chart, and they want us to come up with a diagnosis for it. So I noticed that we've got 2 answers with the 10. Do we have 1 diagnosis or do we have 2 diagnoses? And then our levels are usually not the 12 and not the 15. It's probably a difference between the 13 and 14. And then data can be confusing, so we need to make sure we're paying attention to whether we're billing for stuff. And if we are, like last night, we're not going to capture that as data. But if it was ordered previously from a previous visit and we review it today, that's another guideline that we don't count it. So we got to be very careful with data. It is a difficult component of MDM to grasp all the little intricacies of. It's one of the more difficult ones for me. I think this case has 4 pages. So we have a patient who's here for a recheck for hypertension. Looks like we're working on her bones and joints. She's having difficulty with lower back pain. It radiates. She's being followed by another doctor who referred her. She underwent some testing. She did have an MRA of her extremities. She had a nerve conduction. It showed polyneuropathy. She had a myelogram, but she didn't have the results yet. They think she's had a vertical shift. Vertebral. Okay, vertebrae shift. How about that? She might have surgery in the future. They did her weight, her blood pressure, vitals. Her note was signed with hypertension, spinal stenosis, and signed by the doctor. What level visit would you do for today? What do you guys think? Yes, Yasmin, I did answer it. You asked about if it was beneficial to ask those questions or practice those questions, I thought. Oh, what's the difference? CCA is basic medical coding for like a doctor's office at like pediatric specialist or something like that. CCS does physician offices and hospital coding. I think CCS is more popular with employers than CCA is. CCS, you pay for one attempt. If you do not pass, you have to pay for another attempt to take it, and you have to wait 90 days before you attempt the exam again. With CPC, it's sought after by employers, just like CCS is. If you pay for an attempt, you get 2 attempts at the exam, and there's no waiting period between exams. You can take them back to back. And in fact, if you fail both of those 2 attempts, you can buy 2 more attempts and take them back to back. There's no waiting period. If you were asking me if you needed to do CCA or CCS, I'd prefer you do CCS. I think it's more sought after than CCA. RV is lost in CPT coding. You're okay with ICD-10 coding. Great. I should be able to help you. So let's see. We know our 3 components of MDM are problem list, data, and risk. The problem list seems to have 2 chronics, right? Our data had, what all did this doctor go over? There was Okay, an MRA. I gotta write all this down because I won't be able to. MRA. A nerve conduction study. Was there something else? Oh, and the myelogram. M-Y-E-O-gram. 3 unique tests there for sure. So we had 3 unique tests, and then the doctor did not order any meds that he hadn't already ordered before, and didn't do any other additional testing. It didn't update prescriptions, didn't update referrals, didn't do much. I should have had, where is this book? Let me get you guys a view here. Whoops. Where are we at? Right here. So if we're in our CPT book and we go to E&M guidelines, and we go to this lovely chart, let me get rid of this. Get rid of that. There we go. Where do 2 chronics go? One of them is exasperated a little bit, but that's moderate, I guess. 2 stable chronic, but it could be 1 chronic exasperated and then 1 stable chronic illness. Our data with 3 unique tests is under moderate, and then our risk was minimal to low, if anything. And then we've got to deal with our diagnosis. No results on the myelogram. Cut you back down to just a 2 unique thing. If we had 2 unique, oops, sorry, I'm trying to show you guys and you're not looking. So if the myelogram wasn't there, then we only had 2. That knocks that down to a low under data. Good catch. Good catch. Switch that back. Let me get there. So data could have been limited. Our problem list, limited, could have been moderate, but our risk, even with the referral, maybe continue back seeing that other specialist, you know, that's just passing the buck and not doing anything, but really the risk for what they did, he didn't prescribe any new meds, so we don't have prescription management. I think our risk is low also. So with this being an established patient, we have to do 2 out of 3, right? And 2 of them are low. So B would probably be it. Our diagnosis. We do have 2 diagnoses. We've got the hypertension and the spinal stenosis, so I like C, right? Because we do have 2. I don't know, we might have these wrong, but I'm just playing around. We have, it seems like this data though, several tests. She had the MRI, MRA, she had the nerve conduction study, no results on the myelogram. Did you review any notes from that doctor? Or just the test results? Ah, right here. Reviewed, unchanged dictation from last visit. Okay. That's it. Denies any chest pain. Let's see what they think the answer is. See what y'all are typing in chat. What should you do next? As you mentioned earlier, I think CRC. CRC is where all medical groups are going, hospitals, management services. Everybody wants to risk adjust their patients. They want to find their sickest patients and get those patient services to reduce medical cost. So that is just the ICD-10 book, and your exam is only over the ICD-10. So it is sought after. What are you passionate about? What do you like doing in medical coding too? You tell me, Victoria. Her question was, I think a different doctor is treating her spinal stenosis condition. Do we still code it? Yay, Monique. Glad you're here. Hey, Daniela. So let's see what they said. They do claim it is a 213. They say our data is moderate, not low. And our hypertension is correct. The 213 is because the problem list was moderate. They say the amount or data is limited. There's just 2 unique tests done. And then the risk of complications was low. But here it says the test that was ordered by another provider, because the test was interpreted by the physician over the MRA findings with the patient. The interpretation was not billed. The amount or complexity of the data to be reviewed and analyzed falls under category 2, with an independent interpretation of test performed by another physician, not separately reported. So what they're talking about is, if we go back to our vital source here, is that because we did the independent interpretation of those results, we ended up here in this category 2, where it did not have to, and it could be right here too, but See where it says C, moderate or high on the tail end of that one? If a physician independently interprets a test done somewhere else with the patient, it falls under the or category, or for our moderate, instead of counting it as 2 or 3 or whatever unique test. But it's weird because they asked us up here in the top of this question, what's the amount and complexity of the data? They're saying it's moderate. We said limited. They said here the amount of data was limited too. But then here, when they answered the second question, now they're saying it's moderate. Maybe they have a error in this question. Could be. Maybe I should ask them about that one, because that makes no sense. If it's limited here, then why are we counting it moderate right here? Gotta love aapc. Our diagnosis was easy because we knew we had 2 diagnoses. We had 2 answers with the same ICD-10 code. I wouldn't even bother to open up the book. I would have known, yeah, we definitely have 2, and since we got 2 with the same, and I know in the I section we're close to hypertension, so that would have been confident in just picking C and moving on. Interesting case. I wish I knew 100% why they're saying moderate here and then they're saying limited here, but I don't know. I don't know everything for sure. Here is an anesthesia question for you guys to work on while I catch up with chat. Maybe you guys know something I don't. We do still kind of count that, Victoria, to try to answer your question. We know the patient has this condition. We're choosing not to treat it. We're choosing to delay of care, but we're choosing to get a specialist to take care of it. Give us advice, send us back a note saying how to handle it. So there is a risk there, right? There's a risk of the patient not following through and not going to go see that specialist. There's a risk that when we go to that specialist, the doctor's going to say the patient needs surgery. You know, there's a little bit of risk there for sure. Yes, we can explain some coronary bypasses. Absolutely. Let's do this anesthesia one. I only have 1, 2, 3, 4, 5, 6, 7 questions prepped. And then we can do the coronary ones. Yes, yes, yes. Absolutely. I love to explain those. On this anesthesia one, did we do 1 procedure or 2 anesthesia codes? We have our start time, end time. We have our notes about what was done. Is there anything missing from this anesthesia note that should be there? Do you know a guideline that would tell you right away what procedure or what the answer would be without even opening the book. We did this skull defect on the patient. We did this sinus repair on this patient. We did 3 different procedures. What anesthesia would Dr. Miller charge for this visit? Possibly age of the patient. But more than that, what's our other guideline when we're doing anesthesia? We have in our anesthesia guidelines that big paragraph that says separate procedures. Some of the procedures and services in the CPT code book that are commonly carried out as an integral component of a total service can be given and identified with an inclusion term of separate procedure. Separate procedures should not be reported in addition to the code for total procedures of services. If we put a patient under for a car wreck, let's say, and they have a liver laceration and a broken leg, the anesthesiologist is just going to put them under anesthesia once. 2 different doctors are going to come in. One will fix the liver laceration and another ortho will come in and fix that leg. As long as the patient is stable and can make it through both surgeries, we're not going to stop and do 2 different anesthesias codes for those patients. Which one are we going to code as the total for the anesthesia for that patient? It's usually the biggest and most difficult procedure. If the leg took an hour to do, but the liver laceration only took 15 minutes to fix, then we'll code the anesthesia for the leg fracture. If it was the opposite, where the liver just bled and bled and bled forever, and it took 45 minutes to do that procedure, but then the leg was just a manipulation and popping it back into place, and it was a quick procedure, then we'll code just the anesthesia for only the liver laceration. So knowing that guideline, what do you think the answer is now? Yep, that one often comes up on the exam. Great info. They love that question. Do we always code in order? Most severe procedure? Yep, we sure do. The diagnosis is attached to the procedure, but if you did multiple procedures, as far as the answer goes for AAPC, it'll be all the CPT codes and then the diagnosis codes. A is the answer. Anytime you see an answer that has 2 anesthesia codes, when those 2 codes are both for anesthesia procedures, and I'm not talking about the age one, any of those qualifying circumstance codes that are in the guidelines, but these are like procedures for different anesthesias, procedures on different parts of the body. Those are all coding irregularities because we can't code for 2 different anesthesias. We can only code for one. And without reading one word on this question, you could pick out that that is the only answer it could be for your exam question. But there is something in this note that the physician forgot to add. Do you know what that is on this page? What's missing that the anesthesiologist did not report? Always know where this one is in your book. Every time they say it is rarely, unusual, and variable, that is what's usually on that question for a special report. And then the other one is the separate report right there. Physical status, good job. They forgot to report the physical status of that patient. Yep, they did. Good job. What about this integumentary one? This one will end up being 2 pages long, but we don't read none of that. If the answer was A, what happened to the patient? What was done for today? That's the way I like to do these questions because they get confusing. But if I go to the 17000 and I read my little descriptors, then if this was the answer, how many of whatever did we remove? How many would this be if this was the answer? Good job. What about for B? Usually it's the anesthesia goes first because that's the first thing that's done to the patient, then the procedure, and then the diagnosis. You tell me, Go-Kart, would we need that 59 modifier? Or is that a coding irregularity? Good job, Victoria. Victoria also found a coding irregularity. Our 003 only does up to 14 lesions. So for this to say 17 is a coding irregularity. So you know right away that you can get rid of A and B. They cannot be your answer because those are coding irregularities, just simply because of this. If your answer was C or D, what would be the correct, what would be going on in here? If our answer was C, we've got our 111, which means we did 15 of something. If we did this with this, we had 3 of something, right? If we did this one times 15, when our 111 does 15 plus, that seems weird. Then we've got this one with this one and 3. Would we times that one? Yep. So you know that C must be our correct answer. The 59 would have alerted the health insurance company that yes, we did a bunch of this kind of stuff, and then we had a separate, distinct procedure that took care of these things. So that seems very appropriate. We technically didn't look at one word of that question, and we figured out what the answer was just based off of what available answers there were and the descriptions in the CPT book. What was appropriate for a CPT code in this situation. So very cool. Love this question. We did not even have to look at the question at all. They did do 3 AKs and they did 15 of the other thing. So very cool question. Could you code an E&M with this office visit the way the doctor documented it? We have a patient who came in today and they did all this with it. Could you code a 99213 or something with it? Oh, sorry, Go-Kart, about the ads. Yeah, the modifier in this particular situation is helpful because we have 2 distinct different procedures that were done on this patient. So let's give away some YouTube memberships. I'm going to send some money to YouTube and they are going to pick some winners to get access to 30 days worth of my YouTube videos. I hope that helps out. We got Zeta, Ken, Kim, Naz, and Abril. I hope those help out a whole bunch, guys. So to do an evaluation and management, an E&M visit, and bill for that, you have to have 3 components, right? You got to have a problem list, we got to have data, and we got to have risk. What's inside those includes a history and a physical. Did we do vital signs? Did we take and look at the patient's ears, heart, lung? Did we document that? Did we do an exam on this patient? If we did not examine the patient, look in their ears, down their throat, listen to their heart, take their vital signs, then we cannot bill for it. We do have a history taken because the patient was seen, evaluated 2 weeks ago, and a history was taken and an exam was performed. And these were the treatment options that were given to the patient, was to schedule an appointment for a procedure today. So for today, we can only bill a procedure because we did not do the normal vital signs and make a decision. All we did was schedule an appointment. We had already made the medical decision to do whatever we did to him today, which was destroying and freezing off other stuff. So we just get the bill for the procedures. So the second question I asked about the E&M, no, it cannot be billed for today. Modifier question. I hope those gifts help out, guys. My workshops are really cool on YouTube. You get to watch me do 75 questions in the same pace as the exam, and it's really great to just turn off the volume, don't listen to me, and just bring up those practice exam questions and try to do them in the same pace. Do them in a minute and 50 seconds per question. Pause the screen, let the minute and 50 seconds go by, and the timer goes off, pick an answer, and see if you got it right. A patient presents to the emergency room department with a fractured ulna, and the provider renders initial treatment. If the provider will not be providing subsequent treatment, which modifier gets appended to this fracture? That means the doctor saw them today, splinted their arm, and told them, go see ortho. I am not going to see you back for this fracture. Go see a specialist for this. What modifier would go with the E&M visit or procedures, depending on what they billed for this patient? A lot of times, if you just bill for supplies, like the casting supplies, you get paid more than you do for office visits for fractures. Edith says B, post-operative management only. And who is that? It says C. Everybody else is saying C. What happens in an emergency room when you have a fracture? Are they taking care of post-op after a surgery? Or are they doing pre-op before a surgery? What happens in an emergency room? We're just going to pop the bone back into place or put a splint on it. And that is considered surgical care only. That is the code for ER. What about this one? Which of the following is not included in the service time when billing for conscious sedation? Is it the initial dose, the post services, the face-to-face, or monitoring of oxygen? It's still a surgery. Closed reduction is still a surgery, absolutely. No one can pop a bone back into place unless they are surgically trained, right? It's still a surgery. Remember watching those cop and robber shows with my dad? He had his favorites like Miami Vice or other ones, and I remember Sticks, or what was his name? He was always popping his shoulder back into place. You know, every time I think of those procedures, I think of that show and watching it with my dad. You can't really just bang your bone back into place. You gotta have somebody do it for you. Which of the following is not included when billing for conscious sedation? What do you guys think? Correct. Post services is correct on this one. Good job. OB and delivery. With a tubal, what do you think our answer is? What do you think our answer is? We still got 22 people on, 16 likes on the live. Thank you much, guys. What do you guys think the answer to this one is? The first thing that I like to teach on this one is, ooh, my drawing went away. I don't know why I can't draw. Why can I not draw? That is rude. There we go. We got it back. Okay. In OB and delivery, if the second and third number in the CPT code is a 94, then the baby's outcome, how it got out of the mother, was natural. If it's a 95, it turned out to be a C-section. If the number is a 96, then that patient previously had a C-section. They're gonna try the natural way today, but they may end up with another C-section. It's a combo code. Knowing that fact helps you get through these questions on your coding exam super fast. How did our kid come out today? Came out by C-section. So you know you're not going to have any 94s as far as your answer goes, any at all. So you can get rid of that answer right away. That makes the exam a lot easier when you know our little trick about those codes. Now, did you do one CPT code or did you do two? Are you global, or did you just do part of the delivery? We did the delivery and prenatal, and we did post-op care. So it looks like we do have global. We waited 9 months to be able to bill for this patient and get paid for seeing them. What do you guys think the answer is for this one? Good job. Good job. Yes, it is A. Good job. Perfect. What do we think about this one? What is our header for 99231, 32, 35, and 38? What's the headers for these codes? When you go to the CPT book and you look up 99231, what's the red header? Good try, Robin. I like seeing y'all play around with them, even if you don't have the books. Yeah, possibly Edith. This is subsequent hospital. So is the 232. 235 is OBS with admit and discharge all in the same day. 38, the header for that one is just discharge. What did we do to our patient today? Which one is reported when discharging a patient after surgery when an overnight stay is required? You can also take add-on codes from other parent codes and add those to different parent codes that are not under the add-on code. It's crazy. Look at the question carefully. Which code is reported when we're doing what? The answer's in the question. When we're discharging. Subsequent hospital has nothing to do with discharging. OBS admit and discharge does have a discharge in it, but it also has an admit in it. And there's nothing here that says we need to bill for admitting. It says, what code do we report for discharge? So the only code that is only for discharging is our D. Which of the following statements about EKGs is true? EKGs are not scenario dependent and can be used in all situations. Insurance will only cover for one independent interpretation of an EKG. An ER physician cannot get MDM credit for reviewing a test they ordered. Insurance companies always allow an EKG to be billed with ED E&M codes. When you're doing the wordy questions like these, stay away from anything that says always. You know those answers are never going to be correct in any of these kind of situations. Always, never are really rough because there's always an exception to the rule. So you don't want to have always in any of your scenarios, for sure. So if I get rid of A and D and your options are only B and C, what do you think the answer is? An ER physician cannot get MDM credit for reviewing a test they ordered. Is that a correct answer? We are looking for a true sentence. If an ER doctor sees a patient and orders a EKG, a chest x-ray, and an MRI, they don't get to use that for MDM credit. That's not part of their data. There's a rule about that somewhere. There you go. Insurance companies will only pay for an interpretation of an EKG once. So if an EKG is run and the ER doctor orders it, gets credit for that for their MDM, a specialist cardiologist can't come by and review that EKG, interpret it, even if he interprets it differently and says, oh, this patient's having a heart attack, where the ER doctor says, no, their EKG is normal, and this one says they're having a heart attack. This one still can't get paid for this being part of their data. Only one person can count EKG for data. It's just one of their unique, weird guidelines for one unique test. This isn't true for a lot of things, but for EKGs it happens to be the only true sentence there. It'll only pay for one interpretation of one EKG, not two doctors. According to this lady at aapc. All right. Y'all were asking about, someone was, about cardiovascular. Cabbages, I believe she was talking about. Trying to understand those. That's defibrillators. It's defibrillators. Nope, not there. Not there. Valves. Mitral valves, pulmonary valves. Right here. are grafting. I really like these because they are easier, because everything is either, and I wish I had a blue color, but I don't have a blue color, so y'all gonna have to pretend this is blue, but it's green. The cabbages are split up into 3 categories, and they start off with venous, vein, and I color code these in blue because everything here is all blue. It's all venous, and that's the first thing I'm going to look through my practice exam question on cabbages for is, am I blue or am I red, or am I a combo? So the very first bundle that you get to at 3, 3, 5, 10 is all blue. It's all veins, all venous. I wish I had a blue, but I only have the green. Our next one are the combos. They are the red and the blue. Y'all have to pretend. But they do both the vein, and I color code these with the arterial, the red, aorta, aortic, all of it. So these are the combos, and I would go all the way down and do that for these. And then our last bundle is strictly all aorta. They are the artery bypass with the artery graft. So when you see these questions, first you have to figure out, was my graft aorta? Am I bypass aortic, right? Or did I have a combo with artery grafts and venous grafts? Or was my grafts all venous, vein? And then you just pick out the number. Once you figure out if you're all venous or all aortic or a combo, then you just pick out, did you do 1, 2, 3, or 4? Super easy peasy. Hello, Twinkle Twinkle. You still at work? We are just visiting. I've already went through all my practice questions I had prepped tonight, and I'm just answering questions on the fly. Edith said the titles are a lot for that lady. Gosh, what does she mean by that? What in the world is she talking about? No telling. I think I don't know if my camera, hopefully my camera will be working. Let me see. Let me get to the, let's see, which yearbook am I in right now? That's 2023. I don't know if I did the notes for 2023 in cardio last year. Let's see. Do I have them? I know I've got them in this book. Let's see. Where am I at? 335? Yeah. 335. So, yeah. Three, 5. Yeah. Yeah, maybe I did. I don't like the way they're done in this book. Let's see, 335. Did I do them here? Do I have them done in the 44? No. 335. 335. started prepping the 2024s so you can get an idea of what I got going on and how it looks. We've got our cabbage, coronary artery bypass, vein, and venous, all the way down. Then our next set is artery, but it's combo. We have, come on, we have venous and arterial all the way down. And then our last set is all red with the artery. You just count them. I like color coding them. Makes it a lot easier to answer those questions for sure. Any other kind of questions you guys want to go over? I can bring up a cardiology exam. I can bring up integumentary, E&M, modifiers. These are tiny. Drawing tools. These are tiny. I gotta adjust my font. I haven't done a cardiovascular workshop in forever. Doesn't help very much. That doesn't help very much. That looks so weird with those 26 modifiers like that. That's funny. Can I? No. Extend it. There we go. Got a little bit. Thank you, Go-Kart. Looking at just the answers by themselves, we've got 3 of them that have the 26 modifier at the end. I like looking for similarities. They all have the very first code is the same. Then we've got whether we need to have a 50 modifier attached or not. We only have one that has the 50 modifier. What's going on in that very first code, the 38790? Can we use a 50 modifier with it or not? We got 2, I'm sorry, that had the 50 modifier and 1 without. So 387. What the heck's going on with that code? $38790. That's an injection into a lymph, and it has a parenthetical underneath it. About a bilateral procedure, use the modifier 50. So we can check our question really quickly and see if we did bilateral. We do have it, So that says we got to have it. So then we could get rid of that one. We can get rid of this one because it doesn't have the 26 modifier with it. This one doesn't have the 50 modifier with it. So we know which one our answer is because we know we need to have the 50 modifier. And if we're doing radiology at the same time we're doing an injection, the surgeon gets paid for doing the radiology at the same time. You know you're going to need that 26 modifier, so you know it can't be C. You'd leave off the 26 modifier if the radiologist was doing the radiology portion themselves, but this is a doctor who's doing not only this procedure, but they're also doing that procedure. That's why they get the 26. So, easy peasy. Don't only gotta read one word out of that question. Figure out the answer. These are all formatted totally wrong for tonight because they're so tiny, and I gotta erase all my marks. But I should have prepped more. Got vascular artery embolism, iliac. Make it bigger. Did we do one procedure or did we do 2 procedures? They're the same. Would you need the 59 modifier if you're doing the same CPT code? Is that what you do for that? This one's different from that one, but they're in the same category because they're really close numbered. What do you guys think the answer is for this one? We got rain again here. What do you guys think? What would you do with this question? You usually get the results same day. Even if you take it, well, all the tests are taking online now, so there are no more in person. So everybody that takes the exam, you're either doing it online from your home or you're doing it online at a testing facility. All they're doing at the testing facility is allowing you access to a computer and internet. You're still getting online with a Zoom proctor, and they're monitoring your exam. And as soon as they hit a button and send it to aapc, it gets graded immediately. And you should have results unless you become somebody that is probably one of the 5% that get audited to verify that it's correct. But sometimes those get a day or two delay, but most same day. If you get an email saying you can schedule your next exam attempt and you still had an exam attempt available, then you know you didn't pass. You'll get a grade in probably 20 minutes or so that says you didn't pass. It's time to schedule your repeat. But if you don't ever get that email, then great. You probably passed. Yeah. You see? Come on, margins. Why are y'all way over there? I don't know why. And then y'all need to be bigger. And you need to use up this side of the page. There we go. And that's probably too big. There we go. What do you guys think? We got A. A is correct. Good job. Good job. Let's see about this one. I can make it bigger. Perfect. What do you guys think about this one? We've got 2 with the same answer as the first CPT code. Then there's only a difference between the 84 and the 86 on the second code. That's how I would do it fast. What do you guys think the answer is? Go-Kart says E. You like C? Perfect. No issues there. Y'all are rolling. Let's see. You only need one word from this question to get it right. Oop. Lord, where'd it go? It went way down. Okay, let me fix this for a second. Find y'all one that you hadn't done, or at least seen. Let me get this one bigger for you. And back her up. Okay. Why are you so stubbornly over there on that end? Oh gosh. Don't be going nowhere. There we go. We've got 20, 21, 25, or 30. What do you guys think? B? What's the difference between the 37221 and the 37220? One is with stent placement. Did you do stents? It's hard to tell because probably couldn't see all of the question, but we did stenosis, but no stents. All they did was dilate. Just a sheath, but that's the balloon. A stent is unable to be placed across the stenosis, therefore, just the dilation of the balloon was done. So now you know. Yeah, answer is B or A. What's it say right here? It's saying A. Why is it saying that? Let's see. Vascular revascularization, restore blood type, angioplasty or placement with C. Artery is iliac, eliminating C, therefore the femoral top. D is tibia. Keyword is stent and angio. But it says they weren't unable to. But they still tried and they still get to bill for it? That's interesting. I thought they would have only been able to bill for the dilation. Within the same vessel, open percutaneous iliac artery. That's an interesting one. I would have picked B too, guys. So we can't get all of them correct. They are saying A is correct. They did take out the stent. They did try to put it in there. Maybe that's why. A single balloon deployed stent is placed across the stenosis again, right here, across the iliac into the iliac artery. But they were unable to put it somewhere else, I guess. And then they did place one here. It's just propaganda. This right here is just propaganda. If we'd have looked from the bottom up, you'd have noticed that a stent is placed, and you wouldn't have read any of that beginner stuff. A is correct. They are right in that one. This one you've already seen, the answer is D. Let's see. This one. Let's make it bigger. We've got 3 as the answer for 3 of the answers. So definitely want to take a look at that code, see what's going on there. Looks like we've got a bypass, a cabbage that got done. Remember, finding out whether you are artery or vein is super helpful in these cabbages. So we've got vein, 2 grafts, vein graft, posterior descending, and 1 for a marginal artery. We do have subclavian artery, I'm making comments on my own Facebook post. It's funny. Nobody said they learned anything from me this week, so I added a few things. What do you guys think is your answer? Did you do 3 procedures, 2 procedures, or 1 procedure? That helps pick out the different answers in these. The 37230 angioplasty with several same vessels tripped me up. Yep. Are you an 11 or an 18? We don't have an answer down for this one, so I gotta go look it up. Let's see, 3, 18 or an 11? 3, 5. I have 11. That's 2 venous in a cabbage. Yep. Or 18 is 2 venous in an arterial graft and a venous graft. I think we only did venous grafts, didn't we? 1 for the marginal artery. Quite possibly. We have quite a few of these. If I can do let's see, add. On my website, I've got quite a few of these in the cardiovascular section. Plus, you get to download all my cardiovascular best of best PDFs that are really cool over here. There's a ton of them over here. They're not my notes, but they're still really cool. How do you code this? How do you code that? All separated, but you also get all these practice exam questions. You just click on it and it'll tell you what the answer is. Super cool area. The practice area also has a ton of practice exam questions too. Just click on an answer, it'll tell you what the answer is. So if you haven't played around here, super fun. Also at the YouTube channel, if you go there, there is a community tab right here that has tons of practice exam questions. Just click on an answer and it'll give you the rationale, and they go on for days too. Tons of helpful free info out there y'all can practice with, and try to click on things and see if you got it right. Super cool. They just go on forever, so be sure and practice and get this info inside your CPTs and ICD-10 books, especially stuff like Z codes being first. Tons and tons of if the answer doesn't pop up with the rationale, it took me a minute to figure out how to do that, so the answer will be in chat. But it's super cool with these questions. There's just so many of them and so many free ones everywhere I've got. And then we've got the new membership on my website, and where you can even get access to more. But don't forget about the podcast. Those people that won the YouTube membership, you've got that you can listen to. You can click on the playlist and watch all my old workshops right here. This one's for cardiovascular, the very first one that pops up right there. This is a cardiovascular one where you can just, hit play on the video and then pause the screen at every one of the questions. It'll be 75 of them at least. Super helpful, super fun. The one in December would have been completely free to everyone. I did almost 4 hours of a live there, and then every single one that was dated with April's date on it will be free too. So if there's one in April or the ones in December will be completely free for you guys. So even if you don't have the membership, you can still come here and see quite a few of them, because there's like 3 years worth of free ones and stuff. So anything in April and December are always free. I hope this has been helpful. I'll be live on TikTok this weekend. I don't have a lot going on, finally. I think we got a lot of stuff done. I'll be updating the website so that I can add more questions and more sections. I'm working on adding anesthesia practice questions now. And then I'll add muscle and keep going all the way through all the CPT books. I've got the Cardiovascular for 2024 notes almost finished. Just taking pictures of those. And then I'm going to do Lab and Path. Will be the next one that goes up after that. And then medicine. There is a ton of notes available for ICD-10 also that is super helpful for any of the certification exams. That can help out a whole bunch. If you haven't yet and done or joined our Discord study group, it is super helpful. They can answer a lot of questions when I'm not around. They're a great bunch of people. Go kart, Twinkle, MK, a ton of other people that are always in there answering questions, make things a lot easier for everybody. Plus, you get to search and see a ton of information that we've posted in there for the last 3 years. So you can do searches for your question, and brings up every conversation anybody's ever had about that particular subject, and then you can search for them. Super helpful. Don't forget about the AAPC Edge exams. They are located underneath Training and Events. Go to Search CEUs, then go to Lower Cost. If you are an AAPC member, you get to go there, and every month they will have in that monthly magazine an exam that you can take, and it's free. 20 questions. I try not to pass them so I can save the CEUs. I leave 4 questions unanswered, at least wrong, so that when I hit the grade, it doesn't give me a pass, because I don't want to pass, because I want to save my CEUs. But you still get the rationale with the questions, and there's 20 each month, and they're free if you are an AAPC member. So super handy dandy. You can go back and search through the last 12 months of questions. So right here I can go down to 2023, and then I can look at my prior exams from last year, back all the way to April. Look at those with the rationale, even after I passed already. But they're super helpful. You can practice with those too. So don't forget about that if you are already a member of AAPC. It is super helpful. And if you've run out of practice exam questions, be sure to think about maybe getting you some pocket prep. You can go to my website, and their little link will fly in on this little pink button, and you can click it, and you can purchase right here underneath medical and AAPC CPC 750 practice exam questions for AAPC with an app that will tell you how well you're doing. They do have a pass guarantee if you do purchase them. So super cool. If you do the 3 months for $40 and you don't pass, they'll give you another 3 months access. So super cool. They do come with rationale, and you do get to build your own exams. Like if you only want to do your missed questions, or if you want to build one with all E&M and guidelines, you can do that too. So it's super cool. They're going to be updating their questions this month too, and you do get all questions across all 18 subjects of the exam. And that's how many questions they have for each subject. So super cool. They even have cases right there. They have 75 of those. Just use our link on our website, because if you do, we get reimbursed for those purchases, and then I will use those for YouTube memberships for you guys. So I signed up for an impact program or something, so I haven't gotten any money yet, but they will be sending it through PayPal, I think. And so far, I think we've made $100, so it's super close to that. So that's like that's like 20 YouTube memberships. So I'll be able to give those away as soon as it hits PayPal. But anyway, I hope this is helpful. We will be doing a workshop where I'll do 75 questions in 3 hours on Sunday. Not this Sunday, but next Sunday on the 14th. It'll be free for everybody, so I hope to see you guys there. There's already a YouTube link for it set up. So all you got to do is go back to my YouTube channel, and on the main page right here, it is already set up. I got the cardio picture on it so that it would flash for you guys. So you can already hit the notify me. It'll tell you when I go live. It'll be 2 o'clock my time on Sunday the 14th. And we'll do 3 hours of practice exam questions. Not a lot of teaching or commentary on that day because I'll be doing questions in the same pace as the exam, so I need to get done with them in 120 seconds per question. So I'll be moving pretty fast. But if you guys have opened your 3 books with me and you run to the codes like I am, you'll see what it's going to be like for the exam. So that's super cool. I'll be live again on the 9th here on YouTube, and I've already got that link up ready for you, so hopefully I'll see you on Tuesday. Keep an eye out on TikTok, and when I go live I'll mark it and let you guys know in Discord that I'm going live tomorrow, and we can play around with more pocket prep questions and other Q&A that you guys have tomorrow. But I hope this was helpful for you guys, and I will see you guys later. Love you guys. Thanks, Mabel. Thanks, Go-Kart. Thanks, Twinkle, Maisha, Awesome, Emily, Dawn, Robin, all you guys, Edith, Victoria, y'all were great today. Ken, everybody. Best of luck. Y'all have a great weekend. Do something nice for yourself. Thanks, Shauna. Good night. I will see you guys later. Oh, and don't, I follow everybody on TikTok. If you guys stick around and watch my live for any time at all on TikTok, don't be surprised if I follow you guys. I like seeing your guys' videos too.